digital pathology now gives you that wings that, you can fly and make it a global upfront solution to your problem. So digital pathology makes it more faster. AI makes it more efficient and faster. What else do you need? You are a better pathologist than you were 10 to 15 years back. So I think in coming time, digital pathology and AI is our right and left hand.
I have Dr. Shivani Sharma today with me, who's the Lab Director and Vice President of Pathology Services at Roche Diagnostics, India.
The role of a pathologist has evolved many folds. And what has brought the change is precision medicine. The first person to bring about this evidence is a pathologist. From just being behind the microscope, seeing the slides and giving a diagnosis, we are now the forefront runners who help the oncologists, clinicians, radiologists and everybody to understand the disease better. No discussion on lung cancer would be complete, without saying that tissue is an issue. Because there is so much responsibility on that tiny amount of tissue that we need to be careful from the right first step. The other point that we have to be very, very sure is that we are following the right processes and the person who's looking at the slide is competent, because we should not fall out on that too. So I think it is a clinical, radiological and pathological correlation. If these three get together, the sample is going to be the right, diagnosis is going to be the right, and we are also going to ensure that the treatment also goes right.
Your message to the young pathologists who are listening to you right now?
I would say that just don't be pathologists, be clinicians. Be the guiding light who take the flag ahead and make sure that evidence-based medicine exists for every patient and every patient gets the right treatment.
Hello and welcome everyone. It is my pleasure to welcome you all to today's session where we plan to go inside the lab and discuss the pathologist's role in driving early detection for lung cancer. This discussion is organized by Voice of Healthcare and supported by Roche Diagnostics and is a part of our ongoing efforts where we try and highlight the importance of early detection for lung cancer management in India, and thus with an overall objective to improve the lung cancer care outcomes in India. We all know lung cancer continues to be one of the leading causes of cancer-related deaths in India, and how early detection can play a very pivotal role to manage this stat. While radiology and clinical examination continue to be well known, much of the confirmation and understanding of these cancer-related outcomes goes inside the lab and happens inside a pathology lab. Today, we are lucky to explore how laboratory processes, testing, and technology contribute to be detecting lung cancer at an early stage. And to discuss with this, I have Dr. Shivani Sharma today with me, who's the Lab Director and Vice President of Pathology Services at Roche Diagnostics, India. With a very strong experience in oncopathology and molecular diagnostics, Dr. Sharma has been leading initiatives to improve diagnostic accuracy, integrate AI in work lab flows, and strengthen early disease detection across the country. Dr. Shivani, it's a pleasure to have you today with us.
Thank you so much.
Great. So let's begin with the discussion. Before going very technical towards the evolving landscape and how AI has been in the forefront, etc., let's just begin to where it all started. Today versus a couple of decades back, I'd just like to understand the evolving role of pathologists, number one, in not just lung cancer landscape overall, but the overall, care landscape and diagnostic workflow landscape. How do you think a pathologist is, number one, evolved and involved in ensuring early detection of lung cancer? And what responsibilities fall uniquely within the pathology lab services?
Okay, so pathologist, I think as on today, is not just a person who's giving a name to a disease. The role of a pathologist has evolved many folds. And what has brought the change is precision medicine, the evidence-based medicine which we talk about. This evidence is usually the first person to bring about this evidence is a pathologist. So from just being behind the microscope, seeing the slides and giving a diagnosis, we are now the forefront runners who help the oncologists, clinicians, radiologists and everybody to understand the disease better, to understand what kind of tumor this is, what type of this tumor is, how it is going to impact, and what markers we should do on this tumor to ensure that the right treatment is given. So we've understood in last 2 decades that every patient is different. So the right treatment for the right patient is important. And pathologist here now becomes very close to a clinical workup and clinician, and is a clinician who also gives the input to understand and be the guiding light of how the treatment of the disease will take over. And besides this, there is a huge leap of technology that has come in pathology. We had simple manual small labs across the country, and today state-of-art excellence labs exist in the country where every technology exists, and we are at par with global world. So this has also helped us to evolve ourselves better in terms of what we know, how we know, and use technology to know our disease better. So I think in the last 2 decades, there has been a very big change.
This sure has. And you very well rightly pointed technology, precision medicine being at the forefront of how it has been evolved. But also going a little back, we know that there has been a major evolution when it comes to healthcare industry, specifically in the diagnostics industry. But just for us to understand and simplify the whole process, right from the sample collection to issuing a final report, could you also help us understand the critical steps that unfold in between and to the end process of how we get the sample report, and also in this erstwhile making sure that lung cancer is detected early at the right stage?
Yeah. So we used to always think and actually practice that once the sample has been taken and it reaches the lab, now is the role of pathologist. I think we have to take steps little before. So when we have decided that we have to do a biopsy and go ahead for a biopsy, pathologist enters right there. So once the sample has been taken or has to be taken, what we can do is a rapid on-site evaluation. And for that, the pathologist is right there with the intervention radiologist to tell the radiologist whether the sample is adequate or not. So that's the first point. The next point, the container in which the sample is being kept. To guide the clinician or the people in the hospital to understand the kind of fixative that has to be there, the amount of fixative that has to be there. Then the logistics of the sample. What time will it take to reach the lab, right? And once the sample is in the lab, there starts the journey to now triage the sample. And why I would say triage, because in lung cancer, we have to preserve the tissue. The aim of the entire multidisciplinary team that is working is to get most information out of that sample. So accessioning of the sample, grossing of the sample. And I'll give you a very small example. Sometimes, radiation from the radiologists, we get 2 to 3 cores. And our pathologists, while grossing the specimen, are trained to put it in different blocks, because one block could be just kept for molecular diagnosis. So these are smart moves that you take, and it is so critical for each pathologist in the lab to understand that this is important. And after that, there is the staining process. So what's the prime responsibility? The prime responsibility is to say that this is cancer. Then to say whether it is from lung or a metastatic disease in lung, right? And after that, do further testing to tell what kind of tumor this is, what oncogenic drivers exist there, what are the treatment protocols that could be followed. So in all the steps, the pathologist is definitely involved, but not alone. I would say at every step, the discussion with the clinician and the oncologist is really important, because you might have to troubleshoot at any point of time. For example, you don't get a tissue at all, or you get a negative morphological evidence, you don't see a tumor. So you'll have to rebiopsy. So at every step, it is not pathologist alone, but also the communication with the clinician that makes it possible.
Sure does. And since we're talking about early detection of lung cancer at early stage, we also know that the early stage of lung cancer do not develop, larger lesions. The early stage lung lesions often produce very small biopsies and subtle cytology findings. But dealing with very small sample, what challenges do these minimal samples present to a pathologist specifically or a lab, and how does the overall work flow of a lab try to overcome this?
So this no discussion on lung cancer would be complete, without saying that tissue is an issue, because there is so much responsibility on that tiny amount of tissue that we need to be careful from the right first step. So first is the type of sample. What would you like to get? Is it a bronchial washing? Is it a bronchial brushing? Do you want to do an EBIS? This could be, patient might be having a pleural fluid. So just a pleural fluid analysis with cell block preparation, or you want to really go ahead with biopsy. I would say that from a lot of lung cancer institutes all across the country, we get all of them as samples. And because everybody is trying to make sure that we don't lose out information. So that's the first step, the type. The second is the rapid on-site evaluation, that right there while the sample is being taken, you communicate whether this is adequate or not. So that's the second point. Third, when it reaches the lab, it is very important to not waste tissue at any point of time, right? So everybody should be trained, right from the technician who puts up the stains, who cuts it on the microtome, or the pathologist who's, doing the first evaluation, that I have to save this tissue. Now, one problem that we sometimes face is that the tumor is not adequate, right? And there are some small amount of cells that you see which you're not very confident, to call it malignant or maybe benign or maybe this is inadequate. That is the time where peer review, getting it reviewed by another pathologist or talking to the clinician again, going back to the first step and understanding what should be the next step on this. So all this step ensures that, you're not wasting any tissue. The other is going back to the guidelines. There are standard guidelines. Like first, you have to, where you've already established that this is an adenocarcinoma, you don't need to put a long battery of IHC markers. Just put 2 and save the tissue, right? Then going to the guidelines that now we have next generation sequencing very readily available in the country. So don't go to a reflex testing mode that you first test EGFR, then ALK. Just send the sample for the next generation sequencing where you get all the report in one go. So all these steps, what is it ensuring is that we are not wasting any tissue. But what if we do? So what is the alternative? And preserving the sample. So if I told you that the first step that, we have 4 to 5 kinds of different samples, maybe we exhausted the tissue, but yes, there is a plurifluid cell block, or maybe there is EBUS that we have with the cell block. So we can utilize that. So a person who's sitting with the microscope is not just looking at a slide, is looking at the entire journey of this sample and ensuring that the patient benefits till the result. And all of this requires a lot of intercommunication between pathologist and the clinician, pathologist and the molecular scientist. So it's a big network that needs to work together.
To be honest, it looks so, simple from the outside, but I completely understand how complex it is to, work around. And we simply say that how important is it to, detect early and make sure. But then the complexities that go behind it is very fragile. But since we're talking about early detection, there's also one case that we have to address on, which is false positive, I'm sorry. What are the most common reasons behind false negative pathology reports in lung cancer? And being the lab director yourself, and you oversee all these operations also, being a pathologist yourself, how do you make sure that we minimize these risks?
Okay, so how will we define false negative? We are calling a sample saying that there is no malignancy seen. However, the patient has a tumor. Now, that's a big deal. The first step is that the pathologist or the person who is evaluating the sample should know this, that the patient has presented with a lung mass. The lung mass is of this size. So the correct communication to the pathologist about the clinical history. Is the first step. That when I look at the sample, I just don't put the slide and say, okay, this is negative for malignancy. I look back and see, does the patient have a lung mass? How big is it? How has the patient presented to the clinician? So I need to know that story that happened inside the chamber of the oncologist. Once that is there, then I know that although this sample does not have malignancy, but that does not mean the patient does not have cancer. So I'll have to pick up the phone, discuss the case, and understand and tell them that a rebiopsy needs to be done. So that's the first area. You get the right history, you talk to the clinician. But then the other point that we have to be very, very sure is that we are following the right processes and the person who's looking at the slide is competent, because we should not fall out on that too. Sometimes the clinicians get back to us and say that, can you just review it again, because I'm very sure that this is malignant, So this communication back and forth is really important to minimize this false negative. And it is not about doing this again and again or creating some false thing about that, you're calling in and doing that. But I think it's more important that we collectively ensure that this does not happen, because in the end, it's a patient's life.
True. And we're talking about cancer after all.
Yes.
Right, Dr. Shivani. And also, we also briefly mentioned about the evolving role of technology in making sure that the cancer is detected and caught early. There are a lot of, technology and variations that are available. For example, we have reflex testing with us. We have molecular profiling for early detection with us. In your purview, how can reflex testing protocols and early integration of molecular diagnostics, for example, NGS or PCR, can improve the overall outcome and help us make sure that there is an early detection of the lung cancer? And does it also help in reducing delays and initiating targeted therapies?
Of course. So, as I had mentioned before, lung cancer is a disease that needs three-dimensional view. It is not just biopsy, it's not just IHC, it's also the molecular workup that needs to be done. For this three-dimensional work that needs to be done, it is very important that the sample is going once to one center and not, haywire moving to different centers. So what happens is, then when it comes to one center who has all the technologies or the pathways for the journey of that sample at one place, it ensures that no delay happens. Because what we are changing here is also the technology or the departments within pathology. From histopathology, it's going to IHC, and then it has to go to next generation sequencing. So I have always felt that the patient who is sitting far off should just send the sample and finally get a report which is complete. It tells what tumor it is, what subtype, and all the markers done. Now, reflex testing has also evolved in last 10 years. So when we started, we used to say that it's a adenocarcinoma. Then the sample used to at that time go to some different lab, and EGFR testing used to be done. If it would have come negative, then we'll do ALK, and then otherwise we'll do ROS. From there, we have now come to a position that once the diagnosis is clear, it can straight off go to next generation sequencing. We can do the hotspot panel, get all the biomarkers there, do a PDL1 for the immune checkpoint inhibitors, and we are set. So it has not only reduced the time, it has also saved the tissue. So when we started our conversation, these were the 2 points, right? How can we minimize the delay, and how can we use the tissue better? Right. So I think we've brought that together to a very small point. If I calculate all this in number of days, I think if you are doing a hotspot panel and you've taken a biopsy today, within 12 days, you should have everything. But now, as we sit today, we also have rapid NGS coming in, where we can report in 72 hours, the entire NGS. That journey has reduced to just 4 to 5 days. So you send me the biopsy today, in 5 days, you have all the information that you want. So I think reflex testing has changed its paradigm. It has evolved better, and it has made this journey of patient less painful, because the wait is the most psychologically impacted factor for a patient, and we've all worked together in this, I think, across the country, and I'm very proud to say that India stands at the global front. We do huge volumes, we do all of it at a good cost, so I think we are there.
You absolutely are. And since we mentioned about reflex testing, molecular diagnostics, NGS, PCR, we also have to talk about the most trending word today in pathology, which is digital pathology.
Yes.
Integration of AI. Now, we keep on discussing AI, whether it's a hospital setup or a pathology setup or whether it's a tech setup. But it has taken its place in every domain when it comes to healthcare industry. And why not? Because it has created and impacted the better outcomes of industry. But from a pathologist's point of view, Dr. Shivani, what role do you think digital pathology systems, whole-side imaging, and AI-driven diagnostic tools play in supporting early detection and, of course, improving the outcomes?
So I would say that digital pathology and AI are our next right and left hands. A pathologist who is assisted with these two things is better, is more efficient. This is an often asked question to me that, AI is going to take up the job of the pathologist. I tell them that no. And I'll tell you why. With digital pathology, what would happen? You are now open to the entire world. What if today I have a case, which actually happened with one of my family members, that I had a case where I couldn't, we couldn't make out whether the pleura is involved for the lung cancer. And we were all in a fix. Every pathologist who saw the slide was giving a different opinion. So we opened that case to the entire world. And I think we took opinion from 10 different pulmonary pathologists across the world, because digital pathology was with us. So we scanned the slide, we had a link, and in one shot, any pathologist could see and give the opinion. So you imagine you're sitting somewhere with such difficult situations, which will happen in your day-to-day life. Everything will not be easy, however good expert you are. So digital pathology now gives you that wings that, you can fly and make it a global upfront solution to your problem. Coming on to AI. Now, AI will ensure that I don't make a mistake. Bad day, I'm stressed out, I've seen 200 slides, I'm looking at a core, I missed some part. If that is AI driven, that pop-up would come in and that AI would tell me that, hey, Shivani, you missed that small focus on the right core there. So the point I'm trying to tell you is that AI will ensure that you don't make a mistake. So digital pathology makes it more faster. AI makes it more efficient and faster. What else do you need? You are a better pathologist than you were 10 to 15 years back. So I think in coming time, digital pathology and AI is our right and left hand. And it's going to make me a better pathologist if I adapt it soon.
Yeah, I'm sure that it's not going to replace a pathologist,
Yes.
but I am also very sure that the people or pathologists who are not utilizing the technology that is available on hand, they might get replaced by the people who are using the technology. So
I'll just add one point that artificial intelligence has also helped us in making our next generation sequencing analysis better. We have a huge data that comes out through these genetic tests. Analyzing those data, making that faster, because this is a science that is evolving. And we might come back to these samples again to discover something maybe 10 to 20 years later.
Sure.
So AI will help us to do that. AI will help us to make sure that we just keep evolving and making this better. So not just not helping us to not make mistakes, this is also helping us to build up our own science. And that is how we would come to a point where both of these things, digital pathology and AI, will make this science even better. And we are looking forward to it and very keenly.
Sure. Right, Dr. Shivani Veer. As of these conversations have navigated to how pathologist has been driving, the whole landscape of early detection of testing, and then the technologies that we have. But also from a lab director point of view, we have to have a discussion around quality assurance and control around it. From a lab director's point of view, Dr. Shivani, what quality controller lab governance measures have the biggest influence in the overall, quality maintenance of a lab that goes around, and what systems ensure no early lesion or subtle malignant signal is missed?
So I often say that quality is everyday job. You can't sit one day and say that, okay, today I'll look it back into my lab and see whether the quality is good or not. You have to work on this every single day. It's just like exercise. So what we do is the pre-analytic, the analytic, and the post-analytic. So we broadly divide it into three parts. And we ensure that all the processes are in place in the three segments. If there are errors or we find errors, which there are different means to do that. There are internal audits that you can do. There is external quality assurance mechanism, or there are accreditations that you have. So for us, we are a NABL and CAP accredited lab. So we get blinded samples from CAP, the samples that reach our lab, the samples are processed and the result is sent back. If that result has come good, what does it tell me? It tells me that my kits are working fine. My wet lab technicians are doing a good job. Also the interpretation. So the pathologists who are reviewing the slides are also competent enough. But this is a point test. What you need to do is to check it regularly and ensure that a trend analysis is done if there is some error that is seen, right? And this could be anything. Maybe the rejected samples are becoming more. Maybe the negative for malignancy is being reported more. Or maybe we are just, the competency assessment of the pathologist has not been done. So the trend analysis has to be done at length to understand that the post-analytic is also in place. So what I want to bring about is that in the pre-analytic phase, the sample should reach the lab in the right condition. That's one point. While you're processing the sample, all processes that are needed for maintaining and ensuring that no error is done should be in place. And post-analytic, the people who are involved in reading the results, understanding the results, should be competent enough. So as a lab director, I have to ensure that these three processes are intact. And I would take different measures to do it, whether it's audits or it is proficiency testing. But I'll tell you the biggest thing that tells you that something might go wrong is when you've made an error. We all make errors, right? And it's a very rare event. But if once it happens, in a once in a blue moon, we should take it very seriously and go back, do the root cause analysis, to take the corrective actions. And the next is the feedback. The oncologist sitting who's sending the sample to you knows it, what's the lab, whether the lab results are becoming according to his clinical workup. Take that feedback. So if there is a feedback, answer to it, understand it, and be very open to it. The more we are open to these feedbacks, more the processes become stringent. So it is not always a set standard, quality documentation that is going to make your quality better. It's your everyday work. and open to change, open to reform. And see, today we have reached this place only because of that.
True.
So I think every single step is important.
Yes, and you very rightly mentioned about communication, where you mentioned about how communication is also important from an oncologist who's diagnosing and sending the sample to the pathology services. And also, while we were talking about digital pathology, you also mentioned how digital pathology is making sure that you have referrals around and you have second, third, 10th opinions
Yes.
around the diagnosis. But since we're talking about intersectoral collaborations here, uh, there is a very straightaway example of how pathology and radiology work hand in hand, specifically when we talk about lung cancer diagnosis. How do you think, and where we are, Dr. Shivani, are we collaborating well when it comes to pathology services and radiology services, and is it actually helping us improve the overall outcome of lung cancer diagnosis, or there are steps that we still as an industry need to learn?
So I'll tell you, oncologist and pathologist communication is very well established. I have very few examples where I talk to the radiologists, and mostly these are intervention radiologists. So what happens is that when they are doing a difficult case and they know that something is going to, it's an inaccessible lesion out there, or that the patient is not doing well, you won't be able to do a rebiopsy. He'll pick up the call and tell me and discuss the case, send me the radiology images and tell that, okay, this is what it is. And we are always not dealing with cancer. It could be TB, it could be some fungal infection. So the clinical picture of the patient, and we talk together and we understand, okay, fine. Now you understand the special attention this sample gets because it has been discussed. It makes a huge difference. Now, when that slide is going to come to my microscope, I know A to Z everything that has happened with that case. And I know that how me and radiologist will now help the oncologist to take the next step forward, right? So I think this would be the best way to take forward. But I think a lot of work also needs to be done on it, because I am not talking to a lot of radiologists even as on today, although I'm talking to a lot of oncologists. And when we are stuck, the oncologist will connect me to the radiologist and try and understand. This is not just for lung cancer, for a lot of other things. We don't understand each other's worlds, because I don't understand his science and he doesn't understand me. But in the end, it is always a clinical, radiological, and pathological correlation, right? So we three actually are together, and as a teamwork, this is going to make wonders. So if you ask me what is the three things, so I think it is a clinical, radiological, and pathological correlation. If these three get together, the sample is going to be the right, diagnosis is going to be the right, and we are also going to ensure that the treatment also goes right.
But there still is a scope.
Yeah, I feel there is a lot of scope. Yeah.
Right, Dr. Shivani, we very well established how communication still plays an important role. We are there, but I think there still is room for improvement when it comes to intersectoral collaborations. And let's utilize this platform as a method of communication to take it forward. Also, talking about, we've discussed as a lab director how quality assurance is important, lab governance is important, but also addressing infrastructure, addressing staffing, addressing lab design. How do you think that, is it adequate enough, or do you think there are some changes as a professional or as a lab director you'd like to incorporate when it comes to lab infrastructure, staffing, and training or lab design to ensure practice?
Okay, so I'll come with lab infrastructure, and I will be very upfront to say that we as a country maybe are not there yet. There are very few labs in the country who are state-of-art excellence, who have the right infrastructure that is required. But that number is very well increasing. So it is promising that at some time this will be very well established. Now, national and international guidelines exist where they can tell you that, what would be the adequate area, what could be the adequate space, how should the biosafety lab look like, and those guidelines have to be in place, right? While you're deciding the infrastructure and the space. Coming on to staffing, you need adequate and you need very well trained staff for this. Why I say this is because you have to ensure that that sample that has been given to us is processed to the best of the capacity. Now, the training, you may ask that a person you've hired is already trained. It is not that. The person should be able to do innovations and troubleshooting. We get sometimes not biopsies, we get paraffin blocks from different parts of the country and international, landscape. And the blocks are in different conditions. Now, the wet lab team or the technical team should be trained enough to work on it. Ensure that the quality is also maintained. you get the adequate nucleic acid extraction, and the sample is also processed well. They should also be able to decide whether that result is adequate or not. Should we cancel it? Should we give it or not? All of this will only happen if they are well trained. Coming on to the next part, which is a bioinformatics pipeline. This is a very important aspect of a genetics lab. We have these softwares give results, but in a very good bioinformatics team can, catch errors there. Ensure some information that we know, we might not put it there, but we should just note it. This is a whole lot of genetic data out there. They might find something that may be significant for the patient, not for that disease, maybe an additional information. So if your pipelines are not good enough, you won't be able to do that. And the last part comes for the report generation by a molecular scientist. Now here I feel that what we should ensure is that the molecular scientist and the pathologist should be cross-talking. Now what happens is that when this happens, the person who's seen the slide and the person who's looking at the data talk together, understand what has happened and what has come out, and take the necessary step. Sometimes you are in a fix. So orthogonal, some separate testing could be done for confirmation. For example, you found an ALK variant you're not very confident of. We can do an IHC to see that, right? So here again, the molecular scientist will talk to the pathologist and ensure, that conversation happens. So adequate staff, which is very well trained, is the most important part. The last is the capex that you are putting in there. So you need to have the right machines who are taking the data, giving you the reports at the right time. There are no multiple breakdowns. And you have to understand the need also. Now, a machine could be there for a research purpose, which takes huge amount of data, generates a report in 21 days, or you might need a machine that just gives you a report in 4 days. So according to the need that you have, your lab should be equipped, right? And what helps best is to have the good lab practices in place, have your audits and accreditations in place. Because when external auditors come to your lab, when some external person come to your lab, they can pinpoint on the blind spots that you have and you don't see. So all this ensures that you are at the right space. But the guidelines are there. They're very well maintained, and slowly these labs are increasing in the country. I'm very hopeful that someday we'll have a lot of such labs, and we have very good teams in the country. In fact, I would say that bioinformatics is something that India, I think, has the best, because a lot of people are taking this up, and we are hardworking among all people in the global front. So I feel that we have the right people, and a lot of companies across the world are also investing in us. But what I look forward to is something that is made in India, which I think is still not there, because that would be even more cost effective. Haven't reached there, but yes, I feel a lot of players are there from the global front, and but we are doing a good job.
I'm sure we'll be there in a short time. It's good, Dr. Shivani, that you mentioned that the number of good infrastructural setup labs is increasing in India. But since we are talking about the number of labs and the quality of lab here, we also need to talk about the fact that all of this technology, whether it's AI, whether it's digital pathology, anything that we just spoke about during the conversation, is still very confined to metro cities, to the places where we are. There is a still very pertinent, difference of what we have today here in Delhi, Bombay, versus in tier 2, tier 3 cities. So, as a pathologist who actually, or probably as a clinician also, who strives to, make sure that every lung cancer is detected early and they're taken care of well. How do you think us as a nation can ensure that these practices also penetrate to the areas that has still not been to, and how do you think the way forward could be?
I would answer this question very differently. I feel there is a hub and spoke model for everything. And digital pathology helps you to be there. So a person or a pathologist who's seeing a slide somewhere in a tier 2, tier 3 cities can connect and get the report very early on if the digital pathology network is in place, right? I'm talking about a very idealistic situation where, we'll have scanners everywhere and it's a long way to go, but that's how it has to be. Second thing that I have always felt, and I talk to a lot of clinicians from tier 2, tier 3 cities, is information. They just don't know. So it is our prime responsibility, and maybe it's my responsibility, and everybody in tier 2, tier 3 cities, to travel there, talk to the clinicians, the pathologists, communicate, educate them that what would be the right practice to send the sample. What is the journey of this sample? What is going to happen? How can they inbuilt become self-sufficient with this? Maybe there are certain steps they can do there itself in that same location, and this will reduce the journey of the sample, reduce the time. But this needs a lot of work that needs to be done. Now, I have seen that the medical colleges in the country are the entry point for this, and we have large number of medical colleges in various cities now coming up. If we just ensure that all these practices are established there, it will be a great step to bring tier 2, tier 3 cities to that level, because that will be the starting step, and then you can go ahead. This will involve a lot of infrastructure, a lot of quality checks, quality processes in place, because we just cannot do any mistake. We are in a profession where no error can happen. So before we say that sitting here that this is to be the right way, it has to ensure that it's in the right manner with all the quality checks in place. That's the most important thing.
And you very well rightly pointed out that there still is a lot of information and communication gap. They still don't know that these are the possibilities that are still there with you in hand. So I think that is where the start needs to happen. Right, Dr. Shivani. Thank you. We've come to the conclusion of the discussion today. But before I let you go, we do have a very interesting segment where I'm going to ask you to just help me with one word or one sentence of the questions that I'm going to pose to. It's a rapid fire segment. So the first question is, one lab practice, as per you, that every hospital should adopt for early lung cancer detection.
ROSE, rapid on-site examination.
One mistake that most commonly delays diagnosis.
Inadequate sampling.
Your preferred sample type for early detection. Cytology, co-biopsy.
Always be a biopsy.
One technology that will transform pathology in the next decade, as per you.
Okay, so digital pathology, artificial intelligence, and rapid NGS.
And finally, your message to the young pathologists who are listening to you right now.
I would say that don't be pathologists, be clinicians. Be the guiding light who take the flag ahead and make sure that evidence-based medicine exists for every patient, and every patient gets the right treatment. So you are the guiding light.
Great. And with that, we come to the conclusion of the discussion today, Dr. Shivani. It was a pleasure to have this discussion with you. We've been having these sets of discussions throughout the month, ma'am, for the Lung Cancer Awareness Month. And step after step, discussion after discussion, there's only a lot of realization that a lot more needs to be done while we are almost there. But a lot more needs to be done, whether it comes to technology, whether it comes to adopting technology, whether it comes to informing the clinicians out there, or just simple intersectoral communication that we mentioned. So I think we are there, and there's still a lot to go, and I think we would be in a better position in some years and some decades to follow. Thanks again, Dr.
Thank
Shivani.
you so much for calling me. Thank you so much.